In patients with tricuspid regurgitation, important features on general examination include cyanosis, jaundice, the presence of a pacemaker or defibrillator, and signs of heart failure. Tricuspid regurgitation may be secondary to pulmonary hypertension or right ventricular failure. Important primary causes include infective endocarditis, pacemaker leads, and rheumatic heart disease. Examine the hands, focusing on stigmata of infective endocarditis and signs of anemia. Now look for track marks on the arms. Assess the patient's eyes for anemic conjunctival pallor. Ask the patient to open their mouth. Examine the mouth for quality of dentition and the lips and tongue for the presence of cyanosis. The jugular venous pressure is one of the most important clinical signs in tricuspid regurgitation. The JVP has an elevated V wave and a steep Y descent due to refluxing blood through the tricuspid valve. Apply moderate pressure on the abdomen to demonstrate hepatojugular reflux. Important findings in the chest include the presence of cardiac devices, such as pacemakers, evidence of previous cardiac surgery, and displacement of the apex beat due to right ventricular dilation. Assess for a right ventricular heave and a palpable second heart sound, which are signs of right ventricular failure and pulmonary hypertension. On auscultation, tricuspid regurgitation is a soft, holosystolic murmur, loudest at right or left mid-sternal border or in subxiphoid area. Listen for a widely split S2 due to delayed right ventricular emptying and delayed P2. S3 may be present due to a dilated right ventricle. S4 may be heard in severe right ventricular hypertrophy. The murmur may disappear when tricuspid regurgitation is very severe. Maneuvers that increase preload accentuate the murmur of tricuspid regurgitation. These include inspiration, leg raising, squatting, and hepatic compression. Conversely, the murmur of tricuspid regurgitation is diminished by maneuvers that decrease preload, such as expiration and Valsalva. Ask the patient to sit forward. Auscultate the lungs for any abnormalities suggesting intrinsic lung disease as a cause of pulmonary hypertension. Percuss the bases for pleural effusions. Ask the patient to lay flat on the bed. Palpate for hepatomegaly, pulsatile liver, or ascites, features of right heart failure. Assess the lower limbs for edema, pulses, scars, and clubbing. When summarizing your findings, consider the possible etiologies of tricuspid regurgitation and complications of right heart failure.